Hello and welcome to the VHQC move-in call. At this time, all lines are open and interactive. We ask that you please keep all background noise and side conversations to a minimum. If you are not speaking, please mute your line by pressing star 6. You can press star 6 again to unmute your line. Please note that this conference is being recorded, and I will now turn the call over to your host, Deb Smith.
Thank you, Vanessa. And good afternoon, everyone. Welcome to the Move-In Quarterly Data Review call. My name is Deb Smith. I'm the Infection Preventionist for VHQC. And on the call with me today is Carol Whalen, Improvement Consultant working with the Maryland hospitals. I want to thank you all for taking the time to join us to review our progress towards meeting the VHQC CMS contract goals. And I hope that everyone had an okay time getting onto the call today. As you may have noticed, some of our call numbers changed. So if there was any issues, I apologize. We actually had a couple glitches getting on the call ourselves. So that's why we're a little bit late. And just remember, there's somebody right now who's not on mute, so remember to mute your lines when you're not speaking, because this is an open call, so we can share together. We totally understand that your day and your work doesn't stop just because you're on this call. So if you do need to take another call or someone needs assistance, you can hang up and just dial back in when you're finished with your business and get back on the call then.
Hi, this is Debbie from MedStar. Is there any way you could turn up your volume a little bit? We have our phone up as high as it can go. We can barely hear you.
Really? Okay. We passed the test in the beginning. Vanessa, is there anything we can do on our end?
Just to confirm, you are loud and clear on our end. I believe it's on the participant's end.
Okay. Well, if you could just try to speak loudly, it might help a little bit for us.
Oh, that's not an issue for me. Is this better?
Okay.
Typically, people are telling me to dial it down a little bit. So
now I can hear you, but when you were speaking before, I could barely hear you.
Oh, I'm sorry.
This is Rhonda. I was having that same issue.
Okay, can you all hear me now?
Yeah, I can hear Rhonda better too. It just maybe your voices. I don't know.
Can you hear me now?
Yeah, better.
Okay. Well, I will take my headphones off and do this call without the headphones. Let's try it this way.
Okay, that's better.
Oh, good. Good.
Thanks.
Well, and as I was saying, we want to encourage you all to share all of your best practices, your knowledges, and your lessons learned from your infection prevention journey. I'm Deb Smith. These are our team. Carol Whalen. Jennifer Chang, our data analyst for VHQC, is on vacation. And before we let Jennifer take vacation, she did pull the available NHSN data at that time, got the data reports ready and out, and created some slides for us. And then Rhonda Fletcher, who we just heard from just a moment ago, is our project assistant at VHQC, so she's at the office. And I'm sure most of you have had some type of interaction with Rhonda. She's just a phone call away, especially on these calls with any issues or problems, technical assistance that we may need for these calls. So this is not just VHQC's call. This is your call, so it's your time that you can interact with the rest of the move-in providers in both states and catch up on our network progress. So before anybody gets voluntold for the chat monitor for the day, I was just wondering if we have any volunteers who would like to monitor the chat today. It's not a really involved process. We just need somebody to keep an eye on it and make sure that we're answering any questions that are in chat.
Hey, Dan. The network working right? I mean, I can do that.
Okay, I'm sorry, who's talking?
That's great. And I can see the chat bar.
And who is it?
Debbie Guthrie.
Hi, Debbie Guthrie. If you would like to monitor the chat today, that would be awesome.
Okay.
So all you need to do is just alert us, unmute yourself and keep yourself muted during the call, but you can unmute yourself and alert us if there is any questions at all in chat during the call so that we can address them. Sound good?
Sounds good.
Thank you, Debbie.
All right. Bye-bye.
Oh, pardon the interruption. So sorry, but to avoid the echo, I would ask Debbie to please kind of, if you're on a speakerphone, turn the volume down just a little bit. That'll get rid of the echo.
I just muted it if I'm not talking.
Okay, thank you. All right. An important reminder, and I know you all get these from us from time to time, but it is extremely important that we get your data on time each month. The move-in goals are set with an aggregate of the entire network. So we can't accurately benchmark with this network if we're missing even just one facility, actually even if we're missing one unit, because we do it units in the facility. And I talked to many of you. There's IT issues, there's staffing issues, then there's NHSN downtime issues, and other unforeseen barriers to getting this done. So I just wanted to take a couple seconds on this call right now to see if, because you can see how we're not charting and sticking up there, we're not sustaining the 100%. So I was wondering if there's anyone out there that has any ideas about how we can get this done. So the expectation is that 30 days past the end of the month, the data is in NHSN for VHQC to pull. Now, what we do is Jennifer, our analyst, will check that data on the first of the next month. And anyone who hasn't put the data in, we usually reach out to. And then we give it 5 days to see if they can get their data in by then, and Jennifer pulls another NHSN data pool at that point. We'd like to be able to get your data to you that second week of every month. So we're still, as it is with public reporting like this, we'll always be a month behind, but we won't get too far behind. So is there anyone out there that has an idea? You can speak up or type it in chat.
I'm hi, this is Debbie Guthrie. Here at the Southern Maryland, I'm turning my volume down. We try to pick 2 days every month just to work on the data to see if we can get it knocked out.
So you do like
a little bit every day.
Okay, so you do like the 15th and the 20th or
something like that, yeah.
You put it on your calendar as a calendar appointment, or?
Yes.
That sounds like a good idea. Anyone else out there?
Hey, Deb, this is Carol. I just want to, you and I had talked about, thanking all of those that do get their data in on time and how much we appreciate that additional effort that it takes to meet that goal. And I just wonder if any of those folks who consistently do get it in on time have any ideas or can say how that helps them internally, not just to say, check box, I got that done, but to say what advantages they may have of having their data in 30 days out early.
Hey, this is Sue Mason. I'm in with Debbie Malirakis, and one of the things that we do that I think is helpful is we actually kind of have a staggered rollout of when data is available for procedure and data and like denominator stuff for patient days. So we try to kind of go in a couple of times to do that. So, for early stuff, I will try to get in the very beginning of the month to do that, and then our actual surgical procedure information doesn't roll out until like the 20th of every month. And so then once that comes out, then we do the second part. So it's kind of like a staggered amount of information that we do. But it is difficult because even within our own health system, there are challenges with people getting their stuff in, because we also have our own set of requirements within our health system where they have a dashboard that they want to put out, and it is a challenge everywhere.
Get the denominator.
Right, it's the denominator data. Is that what you said? This is Deb.
Yeah, it's the denominator data that holds us up. We're concurrent with everything except for the denominator.
Well, that's another good thing to know. And honestly, what happens then too is when we're waiting till the end, like this last month, the last quarter, NHSN was down. So things weren't coming across from NHSN for us, even though the hospitals were putting it in. And that's why really waiting till the end of that month isn't really the best thing to do either. But if you're not getting any of your, like say, your SSI data till the 20th of each month, that makes it difficult. It gives you a very short time span to get this data in. Maybe what we could ask is if you do foresee that there's any issues before the 30th, before the end of the month, if you'd let us know, that would be maybe we'd be able to help out in some way or assist, or we're always there for, any questions or comments like that.
This is Rita from Suburban, and it does look like on the data that you sent out, you did not include SSI data for our discussion today. It's mostly device-related stuff in Lab ID. And I would say, certainly we have the same issue with getting our denominators for SSI. But if that's not so critical and you're just really going to focus in on device-related stuff and Lab ID, that might be a little easier for all of us, because I think everyone's challenged with trying to get the list for their surgical procedures every month, always, forever, kind of thing.
Thank you, Rita. And actually, that is the truth with, and this gets confusing because you're in so many initiatives, and each one has something else that they're focusing on. So for VHQC and the MVHIN network, it's Claudia CLABC in ICUs and non-ICUs, and CDIS Lab ID. And those are our data goals. That's what's tied to the CMS contract for VHQC. We still get your data for SSIs, and that's so that we can help you with any issues that you would be having during that time, or if one of you wants some data reports on SSI, we have access to that data in order to be able to do that. But if any of you are in a HEN, Hospital Engagement Network also, they need VAE data and SSI data. So we all need something just a little bit different. But that is correct, Rita. It is the device associated and the Lab ID for CDIS. So hopefully that makes it a little easier for everyone. All right, and thank you all for taking the time to talk about this, and also for getting in the data after we asked you to. All right, on to the quality awards. So we've been promising this since we started this scope of work a year and a half ago, that we were going to have year-end quality awards. So we have 2015 quality awards have been calculated. We've calculated them. They're going to be for the VHQC hospitals in this network, and they'll be announced soon. I just wanted to talk about how we determined the awards for the quality awards for the hospitals. So these were awarded to the top 10% in each state. So that'll be 3 awards in Maryland and 4 awards in Virginia. And as you can see on this slide, we've used the HCAP scores and the CAD for all the HIIs in order to determine the top performing hospitals in each state. So each hospital that is receiving an award will be notified, and then a formal announcement will be sent out statewide. So we're thinking that this will be definitely within the next 2 weeks. What we're waiting for is everything to come back from the printer and the awards place so that we have something that we can present to these hospitals when we do present their awards. So is there any questions about this at this point? Hopefully we can announce these soon, because we want to let all of the hospitals know who's gotten the awards. And then we're thinking for next year, one of the things that we will be adding, we may be changing these percentages, so it'll be a little heavier on the HAI. The reason we didn't do that this time was because we really didn't have as much time to be working with the hospitals and analyzing the data, so a lot of it we haven't had time to make improvements on. So the HCAP scores have been out there forever, and we decided to weight them a little bit heavier. With it next year, we'll be weighting the HAIs heavier, and we're also going to add a small percentage in there that will address timely reporting. So we're hoping that that'll be a bonus for everybody who does get their data in on time, that'll help a little bit in the end of the year awards criteria. So any questions or comments on this? Oh, and Becky, I see that you're asking about the HCAP scores. So it's the star ratings, everything that goes into those star ratings for the HCAP. So it's all of the HCAP scores. Does that answer your question?
Yes, thank you, Deb.
Okay. Any other questions? All right, well, congratulations ahead of time to those hospitals that are going to be notified of their awards.
Can I just ask about the notification process? Will just letters be going out to the C-suite, or will we be copied at the same time, or how will that roll out?
It'll probably roll out through your leadership and you. The contacts that we have for the MVHIN network it's you all.
Right.
And whoever signed the letter of participation when we started this work, and also whoever you've designated as a leader in your hospital that you want to get reports to. That'll be definitely, you'll be notified on that. What we're not sure about is whether we're going to be doing it in person or if we're going to be sending things through the mail or that type of thing. That has to be decided through our communications and our leadership at VHQC. I'm hoping that we can do it in person because, it's a big deal. So you will, if you get these, be notified. And then, of course, we're going to send out some type of communication to the states to let them know who has received these awards through VHQC. Any other questions? All right, anything you have to add, Carol?
I don't think so. I think that covers it pretty well if there's no questions from our participants.
Okay. Now, something that I did not get into the slides today, because we're still really working on figuring this out ourselves, but the data reports for VHQC now are being sent through a secure file transfer called BOX, B-O-X. You should have all received an invitation to join BOX. If you do not remember receiving it or didn't receive it, it may have gone to your spam folder. This was a good month ago or longer, and I know that some of your spam folders delete themselves after time, so Carol and I are going to be sending these invitations with instructions back out again. We've decided that we'll send you, quote unquote, a warning email that you're going to be getting this invitation to BOX and the instructions so that you know to look for it in case it does go to your spam folder. You can go in and look at your spam folder. And then we'll follow up that email telling you you're going to get it with the actual invite and the instructions to get into your BOX, to set up a BOX account and access your folders. So we'll follow up that with another email, making sure that you actually did get in. And sometimes we've had to put the IT departments at your hospital in touch with the IT departments at the VHQC office so that they can talk and allow that access to the BOX. And the BOX folders. So is there any questions about that right now? Like I said, we're going to be sending this all out again. Yes.
Hey, this is Linda Stokes. I did get that email, and I was successful in setting it up, but when I tried to get into the BOX, my Duke network would not allow me to access it. So I'll wait till I get your new email. We'll try to get, and it even popped up on my phone and everything, everywhere. I got the BOX, but when I try to access it, it says it's, the access is denied.
Do we have others with that same issue?
Yeah, this is Becky. I had the same problem. My IT department was able to fix it for me, but they actually had to request from LifePoint more access on my computer. It wasn't a simple process.
So Becky, though, I want to ask you, so after you went through because I get that, trying to work through IT, especially in the hospital where they've got lots of things that they've got to be monitoring, after you were able to get that access, do you feel like it's a worthwhile, valuable, easy-to-access system then?
After I got access, yes. I wonder if you're sending it the same way, like to the O's, and they probably have that better access, so they don't have to jump through the hoops that we may have to.
Well, and that's one of our concerns also, and further on in the presentation I was going to talk to you all about that too. We aren't sure that the leadership is accessing it either. So possibly they ignored the invite to begin with, and you know how that is. I don't know about you all, but if a week goes by, my emails just pile up so far that when you're trying to go back and try to find an email that's even greater than a week old, it's almost in no man's land too, even if it didn't go to your spam folder. So that's why we thought that we'd send it all out again and try to get this process done.
Deb?
Yes.
This is Rita from Suburban, and so I guess we were lucky in a way because we already were using Fox through Johns Hopkins. So using Fox was not a new concept, and it was so much easier for me to be able to see my data as opposed to the previous way. So I say, that my preference would be to keep it in this delivery system.
Well, and I have heard, thank you, Rita, because I've heard that from those hospitals that were able to get in. Because I think, so Debbie and Sue, you were able to get in for Bon Secours, correct?
Yes, we have been able to, and I think some of the commercial ads have decreased. So thank you very much for whatever you did to help that.
Right. Well, and I don't know, is it commercial ads or is it helpful hints? But they're all about the same.
And that's a good, Deb, this is Carol, that's a good point. I believe that John sent out an additional instruction sheet to turn off those notifications from bots. So we'll be also sending that update so that if you prefer not to get those notifications, advertisements, whatever they are, newsletter type stuff from bots, you can turn that part off. But let me back up just a minute and make a clarification. There's a notification that you want to receive, most likely letting you know that new data has been added to your box. You don't want to turn off that notification. You want to turn off the notification that says newsletter. Okay? So we'll send those instructions out as well.
Thank you. And I have to admit, Carol has been in the box much more than I've been in the box. So she's really the expert on it, and I've been leaning on her for some of this. So we'll all work through it together, but I have noticed that even for myself, I had access to all of these files on my desktop or through our secure server with VHQC, and being able to access them in Box is so quick and easy because, of course, I have access to all of Maryland and Virginia's files. And I feel like it's easier to pull up. You don't have to worry about, you have one password that you set up your Box account with, and you don't have to worry about those encrypted emails again. So it's just all in there. So it really is, I think, worth the time, hopefully, for all of you to take that time to set the account up.
Yeah, I think it's worth the time for us. I'm just doubtful that many of the CEOs will take that time.
Well, and so hopefully then my request for you all, once you get into the box, to print off your leadership report. And that there is somebody out there who does not have their line muted. So anyways, that you could print off the leadership report and get that to your leaders. Because I'm under that same impression. I don't think that they will take the time And for a yearly report, they maybe don't need to take that time. So the IPs and the quality and anybody who does have access to the box, if you all could just print that off and see that your leadership gets it, that would be wonderful. So saying that, we do have the leadership report. This is just a mock-up of what we sent out with the leadership report. So anybody that's been able to access Box and see this, hopefully you felt that this was a great snapshot of what went on with your hospital compared to the MVHIN network during 2015. Is there any discussion out there about this report?
I thought it was an extremely efficient way of displaying your data. This is Kevin from Fort Washington.
Thank you, Kevin. Yeah, I think it looks like something that you can look at in one page and kind of see exactly what's going on with your hospital compared not just to the MVHIN network aggregate, but also to the national SIR and the state SIR. And then it's color-coded. The second page of this is by, oh no, this one does, I'm sorry, I'm getting confused. This one does not have a second page. It is just a one-pager for your leadership. So all of the graphs are down on the bottom. It also gives them trend lines. Now that being said, I also want to bring up one issue with targets, and I know Sue Moslin is on board with this. Each one of the initiatives that you all are in probably has a different goal and target that they are using. VHQC, through our contract with CMS, is using the national targets and the state targets that come out with the report each year. So that being said, whenever we run TAP reports or anything else, it is not the HHS goal, but it is the national SIR goal. So you will be getting other reports from other organizations in your state, and their numbers may be slightly different from VHQC's. That's one of the reasons that that might be happening. Sue, did you want to say anything else about that?
No, but as predicted, the report that we got from VDH has stimulated quite a bit of discussion.
And I know Andrea's on the line, so when we get to our stakeholder updates, I think she can probably address that. So on to the Virginia HAI network data. So this is overall what Virginia is doing within the network. And as you can see, we are tracking CLADI, CLABSI, and ICU and non-ICU, and CDI facility-wide. So on this chart here, we have the number of infections that we had for each of these HAIs, the expected number, what the network SIR is, and then that's compared to the national SIR. The state SIR is the last column, but 130% of the national SIR is the contract goal for July of 2016 for Virginia, for VHQC. So with Virginia, we're performing better than the contract goal and actually the national SIR in CLADI, in CLABSI non-ICU, or ICU. In CLABSI ICU, we're just under the 130% contract goal. CDI, we're under it. Any questions or comments on Virginia data?
I would say congratulations. That's quite remarkable. Great work, everyone.
Well, and we're hoping to continue this this is data up through March. The measurement period for our contract deliverable is May 2015 through June 2016. So we still have a couple months of data to calculate in here, and we're hoping that this trend continues. And then with Maryland, we're exceeding the contract deliverable and the national SIR for CAUTI in Maryland, doing a really great job in that. For CDIF, we're meeting our contract deliverable for July, but for CLABSI, in Maryland, we are not meeting the contract deliverable, and it looks like, with the data that we've been looking at and projecting that we may not meet that deliverable for July. Some of you all have benefited from site visits from VHQC, and we might be making more of those, but those site visits were more not to necessarily put into place any new quality improvement plans, but they were to go out and just make sure to do an audit or validation of the CLABSI events that have already been called, along with the annual survey and unit mapping, which are two other things that can affect the SIR. So we may be reaching out to more of you to do that type of review. It's very helpful. The hospitals that we did go to last week were actually happy to have another set of eyes on their data. It's always good to be able to bounce things off of someone else. Any comments about this data?
Deb, this is Carol. I think it's interesting to see that the number of events for CLABSI in both ICU and non-ICU are lower than expected. So we can see here that the hospitals have been working very hard, I believe, into reducing these events across the board, and I think that work needs to be recognized. However, we're still above the national SIR, and so as all the hospitals are improving nationally. So I think that's part of our effort, is to realize that even though we are making good progress, nationally hospitals are making progress on what they've already reduced as well. So it's a constant challenge, and I just want to recognize the work that's being done and just, encourage everyone to stick with it and to continue on that journey and be passionate on getting these events even lower.
Thank you, Carol. I feel like today that we're being good cop, bad cop. So I'm really glad for the...
We didn't plan it that way.
I know, but I'm really glad for the input that you put into it. Thank you. And as you can see, 0.65, an SIR of 0.65 is a low target to be meeting. So whatever we can do to help, we're there to help. And as Carol said, there's a lot of work, we understand that goes into this daily.
I have a question.
Yes.
It's Rita, and it would be interesting to hear if there are particular central lines that are causing these CLABSIs. I mean, it seems like it's probably more PICS in the non-ICUs, but it would be interesting to hear if there is a higher percentage of CLABSIs in certain central lines to maybe focus some other efforts on management of them or something. Or maybe there's no common denominator on that.
Rita, I'm not sure if there's a common denominator overall, but that's a very good thought to look at.
There have been, and as far as PIC lines go, sorry to interrupt, but
no, go.
There have been conversations on and off over the years at Suburban. Are we interested in looking at midlines? Are we not? How are we going to train people? And move forward with that, because the feedback from some of the physicians and nurse practitioners and even some of the nurses here indicate that sometimes we do put PIC lines in when maybe we could get away with something else that's a little more intermediate. So I'd be interested in hearing if other people are having success with doing that and getting away from some PIC lines.
For those of you on the phone, does anybody have some input on this, whether or not you're evaluating for midlines when you get an order for PICS?
Deb, this is Diane Jones at Central Health. Yes,
Hi,
we
Diane.
have evaluated the midlines, and we're using them. I don't have enough data to say how much it has decreased yet in terms of using the PICC line. So, but our vascular access team did put that together, and they are inserting midlines with some success, some a little pushback in some areas, but it was a welcome change to see that for us to go towards those midlines. And the other question I have, that 0.5 on the CLAMSY, we're not going to be able to reach that in the ICU. So I just wanted to know if anyone is doing anything, we've got the bundles, we've got the disinfectant caps, or is there anything else going on that is really driving that target to be that 0.5? Because that is very tight for us, and just interested to see if there's anything someone has done in particularly they feel like that has really made the difference.
This is Susanna from Virginia, and from Pennsylvania Regional, and we're using CHG dating on patients in the ICU, universal decolonization actually, in patients in the ICU, and we haven't, we can't say that that's it, but that is something that we're doing above from the bundle. We're also using CHG bathing on patients with central lines.
Outside the ICU?
Correct, outside, yeah. But the universal decolonization within the ICU, and I know that can be controversial, but we're using the Terracin for 5 days, and then the CHG bathing. So that's just another thing that we are doing besides the bundles, and we've done very well. We've been three plus years. We have a very small ICU, but no collapses in our ICU.
Okay, thank you. We do the CHG bathing, but we haven't done the Terracin decolonization, so thank you.
And Deb, I have a recent article about the Michigan Appropriateness Guide for Intravenous Catheters. It's called The Magic. I don't know if you guys have seen that or not, but it's a great article around using those PICC lines and moving to more midline approach. So after the call, I can send that out to everyone to have some current research for you as you begin to look at that if you haven't already.
Great, thanks. This is Susanna again. I just have a comment, too, about CLAPSIs. The CLAPSIs we have had outside of the ICU have been, again, we're not a very big hospital, but we've had a few with patients who are with a history of IV drug use, and we've had challenges with replacing a central line when they need it, but then having to have, a one-to-one and keeping them safe and stopping that from being accessed from not the medical staff. And so we've had a couple of CLAPSIs where the pathogens in play were ones that were likely from manipulation from the patient themselves. And I just didn't know if anyone has had that experience as well, and if that kind of plays into any of this CLAPSI rate.
Susanna, this is Heather Enrico. We have definitely seen that in the past. We've had several CLAPSIs that were a result of suspected access of the line. However, starting in January of this year, those no longer count as CLAPSIs as long as it is documented, as long as the nurse or the physician documents the suspected access of the line. I don't know if you had seen that. Kim actually brought it to my attention. I completely missed that little statement in the
I did not see that. Thank you. We haven't had one since January. But that's interesting. I just didn't know that. So as long as it's documented, so there's a place in NHSN criteria that says if it's documented?
Yeah, it's in the CLAPSI chapter, but it has to actually be documented in the medical record. So I know for us, like the couple we've had before, I only found that out because the nurses told me, we think they were accessing it, but they hadn't documented it. So we've been doing some education to make sure that they actually document it.
Okay, all right, good to know. Not that, you still want to avoid them, but it's interesting, so that won't go into it, that won't skew these classes.
Right, you won't have to report
thank you.
Anymore.
Okay, thank you.
Thank you for bringing that up, Heather. That is true. So it's starting in January of 2016. So, Savannah, hopefully you can take advantage of that moving forward. Any other discussion? I do know that during the site visits last week, one of the other risk factors that I identified in one hospital in particular, but other hospitals may have the same issue, is dialysis catheters. And whether or not it's happening in dialysis or care and maintenance on the floor, and also whether or not others, like maybe the ED or somewhere, may be accessing those dialysis catheters that shouldn't be accessing them. So any discussion on that?
This is Heather Henrico again. We have definitely seen that, and our nurses are, the nurses that are employed by the hospital don't access those dialysis catheters at all, and they don't do the dressing changes either. It's all done by DaVita. So I know that's it often gets people upset when they have a clad fee attributed to their floor when they never even touch the line.
Right.
But we have definitely seen an increase in those, and we've talked about looking at antimicrobial dialysis catheters. But the problem with a lot of our patients that have infections, when I look back at them, we're not the ones who inserted the dialysis catheter. They're people who are coming in with them already in place. So I don't know that would really help us any.
Right. Any other discussion on that? That may be something that we could use as a webinar topic moving forward. More to come on that.
And then I posted a link to the magic article that I mentioned earlier in the chat box, so you guys can just copy that and paste it into your address line in your browser when you get a chance to take a look at that.
Did you send it to all the attendees?
Yes, to all attendees. And I believe, in sharing, Deb and I will be setting up a small group call for our hospitals that show opportunity in this area, so that we can maybe look at what type of lines, if we do have any trends going on, and we can take a look at that in Maryland.
Well, and thank you, everyone. That's great sharing. That's what these calls are supposed to be about. I'm going to quickly go through some of the rest of these data slides. This is no surprise. This is the network together, the regional network, that ICU units for CLABSI were meeting, but not in non-ICU units. CLAUDI and CDIF, we are meeting our contract deliverable for 2016 July. We also track the regional DUR, device utilization ratio, for indwelling urinary catheters, and we're doing quite well on that. You can see our contract deliverable at the end of the contract is 80%, but for July it's 60%. And we've got quite a few of our units are meeting that. We're close. So one of the issues is that as we do reduce line days, sometimes the SIR goes up. So, there's still that correlation going on, but keep up the good work there. I did quickly want to show you all the monthly reporting format. So if you haven't been in box yet, you may not have seen this, but once you do get in box, you will see that our monthly reports have changed just a little bit. This is a sample of the CLAUDI and DUR report. So this also is more streamlined so that we don't have all of those different files that you have to open for each and every unit. That got cumbersome. I'm sure you all felt that same way. And hopefully you appreciate this work that Jennifer did on this report. But this is the 2-page report that I was discussing. The second page of this does give you each one of your units, and it shows you what the number of infections was, because this is something that a lot of the hospitals were looking for. we're still doing a rolling year, but you'll be able to see for each month how many infections were on each unit, and that way you can do your own validation because it was difficult for hospitals to be able to track their own data with the MVHIN network data. Those little trends down there, there's no data marks associated with those trends, but it does show you the trend lines for how each of your units are trending. Any thoughts or discussion on these new, the new monthly format? Hopefully once you're all in box, you can let us know how it works for you. It seems to me like it would be easier to use this to report out at meetings. These are when you get your quarterly data, you also get the closer look data. This is the network data, and you can see, like for this CLABSI, there's quite a few hospitals who are maintaining 0 yet, but then there's a couple hospitals that still have some room for improvement. The same thing with Maryland, and then this is C. diff. There's less hospitals that have 0 C. diff, so we have some room for improvement here also. And we didn't have the CODI closer look slides from Jennifer, so we'll be showing that on the next quarterly data call. Just want to remind everybody that these regional maps are out there on the VHQC online community. They're really nice to use. Like this particular one is the population of patients who are greater than 65 years of age. And with the dots on the map, of course, you can see there with the legend that the larger dots are an SIR of greater than 75. This happens to be the CLABSI map showing in relation to patients that are greater than 65 years old. And then, of course, you can see where the patients are. So, you know, if you're up in one area, you see that you have a high SIR in that area. It may be related to the mix of patients. Same thing for CODI. These maps are all on the online community.
Deb, I think we might just want to say about those particular maps is they're based on the hospital compare data and not on our most current performance. Right. Yeah.
With the most recent hospital compare data, I'm not even sure when it was. Does anybody out there know? I think it was second quarter 2015, but I'm not sure. I think because we do have some stakeholders on the line, I'm going to turn the call over to Carol. We've had quite a bit of open sharing, so I'm going to turn the call over to Carol right now so that she can get some reports from our stakeholders. Thank you.
Okay, so keeping our timeline and being respectful of everybody, I just want to say thank you for all the interaction on the call today. Deb is exactly right. That's what these calls are for. But we also want to give our stakeholders an opportunity to update our network on what's going on in our respective states. And I know that for sure on the line today, we have Justin from the Maryland Hospital Association. So Justin, I'm going to go ahead and let you go first because I know you're on here, and then we'll open it up to others that are on.
Hi, I'll be quick. Thank you. So really there's a couple of things I probably want to highlight. We're trying our best to help our members address HAIs through a couple of efforts. The two ones I'd probably highlight are, first we're looking at creating virtual communities in the near future. So we have structures in place now, such as our Council on Clinical Quality initiatives, that kind of help facilitate long-term strategic planning. But we want to be able to provide in the near future is a structure whereby experts and infection preventionists can really more readily share knowledge and best practices with each other on more immediate concerns and topics as they come up. So if a clinician has a question such as are there peer review processes or protocols regarding how frequently certain kinds of dressing should be changed, then there'll be a medium for that person to reach out and get an answer in pretty quick order from one of their colleagues who's doing it on the ground floor, on the ground level at another hospital. Another thing we're doing is to continue to support our partners on all of their collaboratives. Certainly I'll let them speak to what those collaboratives are and give more details. But to that end, one thing I did want to point out, an interesting opportunity was recently presented by the American Hospital Association in partnership with the CDC, which really aims to reduce C. diff and other HAIs and would require extensive cooperation between MHA, VHQC, and VHMH. It's something some of our hospitals may want to be involved in, particularly those who aren't already involved in an HAI collaborative with VHQC. But we're going to need some more time to convene with hospital members as well as other partners and process if this would be an engagement that everyone wants to partake in. Finally, I'll just touch on hand hygiene data collection. Hand hygiene data is something that MHA has been collecting for a while, and hospital staff have steadily been increasing their compliance. The topic was also discussed at the Council on Clinical Quality Issues as well as our executive committee, and it was decided that hand hygiene data collection programs should continue for another 6 months at least, but with the caveat that over that next 6 months, the process or methodology by which the data were collected would be reevaluated. Specifically, right now, it's collected upon entry and exit into patients' rooms. There's some thought that there might be better methodologies out there that could be leveraged and kind of be more in line with HAI reduction efforts. One of them that was mentioned was the WHO's 5 points. So what MHA is charged to do by those councils over the next few months is reach out to hospital members, work with our various councils, and try to get feedback as to which methodology we should switch to if we want to switch methodologies at all. Because there's a lot of interest in really, like I said, leveraging that hand hygiene data collection to make sure it's also contributing to HAI reduction. That said, I'll just kind of wrap up with the general. If anyone has any suggestions, questions, please, I'm always accessible. Feel free to email me at any time. I'm thinking everyone here has my contact information. If not, please feel free to reach out to Carol, and she can certainly give it to you.
Okay. Well, thank you, Justin. Does anybody else have any questions of Justin at this point? Okay. All right. So, Andrea, I think you're on the line from Virginia. Do you have anything from the Department of Health in Virginia to add?
Yes. Hi, Carol and Deb and everyone on the line. This is Andrea, the HI coordinator from the Virginia Department of Health. The two communications that our Virginia IT colleagues have received recently are facility-specific report sharing, CDIF and CAUTI data, and that particular report was on behalf of the State HAI Advisory Group, and as Deb and Sue Mason alluded to, the targets of our state and specifically the State HAI Advisory Group align with the Department of Health and Human Services, so those targets are lower than the national SIR from 2014. So, two different targets, and hopefully didn't create too much confusion as we try to put in the context of this is our state HAI Advisory Group goal. But just wanted to make that clarification about the two different targets. And then in preparations for a 2015 annual report that the Health Department will eventually be putting out later this summer as our target for publication. We're doing a round of quality assurance. So facilities should have received a facility-specific report for some data to review, in some cases outlier data or variables that could indicate a data quality issue, and then others just an eyeball check to look at your SIRs. So thank you for reviewing those reports and sending back the acknowledgement form to say, yes,
I looked at this report and made any changes as appropriate in NHSN. So in some cases, there may be no changes to be made, and in others, there may require some work to look into some of the data quality reports. And just one other thing, note that CMS recently published a proposed rule for public comment. And I'm sure we VHQC and the health department can follow up with more details, but just a heads up on proposed changes to the hospital and patient quality reporting program. They're proposing to add that hospitals would report the NHSN antibiotic use measure to CMS as part of the hospital and patient quality reporting program, and but no additional HAI infections would be added to public reporting. And as a side note, the hospital compare will be showing long-term acute care hospital data later this fall. There'll be 4 quality measures on hospital compare from long-term acute care hospitals if any of your facilities have one of those. So those are my comments. Thanks for the opportunity to share.
And thank you, Andrea, for that. You guys, we're at the top of the hour, and I understand some of you are going to need to drop off, but we're going to wrap up the call here very quickly. Is there any other stakeholders on the line that I haven't mentioned before I give Katie Richards' report from the Maryland Department of Health and Mental Hygiene? I don't want to miss anybody that's on the call.
Yeah, Sue's here. I'm the Virginia APIC president, so I think I can say a couple words just briefly. Looking at we have a conference coming up in October all about risks, improving outcomes through reducing risk, and a lot of the things that we're talking about on these calls, we do have speakers coming to address, like for CDIP, looking at antibiotic stewardship, reducing risks in all the, I know that our focus here is mostly acute care, but reaching out towards the ambulatory centers. We were going to have a whole ambulatory group coming to talk about, specific issues that they have in their practice areas, physician office practices, ambulatory surgery centers, long-term care, and home care. So we're hoping to, get a good showing for that as well.
Lots of work going on with our downstream and community providers. So it's great to be ahead of the 8 ball on that. Anyone else?
Cheryl, this is Ellen from MVHQC. I just had a couple of quick updates. I know we're running out of time.
Perfect. Go ahead.
Okay, thank you. We're going to be pulling 2015 data for quality and SSI and the flu vaccination summary for healthcare personnel tomorrow for a preview report that will be sent out next week to the hospitals, and data will be publicly reported on our consumer website in June. We're also finalizing the SSI procedure review results that will be sent to facilities this week with the results of a review that was done with NHSN and administrative claims data. And then the last thing was we recently completed a targeted on-site audit of quality data, and we're planning to have a webinar in June to review the results of that. So that was it. So thanks a lot.
Oh, you're welcome, and thanks for letting us know what's going on and keeping our hospitals informed of the latest and greatest, everyone. Also, Katie Richards submitted the report about the cause, the campaign for appropriate antibiotic use. So she wrote a really nice little paragraph update that I will send out to everyone on the call so that you'll have that in writing. But in lieu of what Andrea said about the new proposed antibiotic use measure, I think it would behoove everyone to take a look at this cause campaign and make sure that your hospital is signed up to participate in this work. It's really going to help prepare the hospitals and get them ready to meet this the requirements, the CMS requirements moving forward. Currently, there are 16 acute care hospitals, so you want to make sure your hospital is one of those. Anyone else? Okay, Deb, we were ready to close this out. Just, you guys, in the handouts, there are slides about the educational offerings on the online community. All the recorded calls are there. Our next call will be August the 16th, in which we'll do another data review. In between time, we plan to have a small group call again to address our CLABSIs in Maryland, and we want to say thank you for your active participation and engagement on this call today and for all the work that you do every day on the front line. So unless there's anything else, Deb, do you have anything?
Nope, just thank you all, and I put in chat that the next call, we're definitely putting the stakeholders first, because we do appreciate that support from you.
Absolutely. And so just as a reminder, make sure we have your correct CEO information so that those reports can get to the right person in your hospital. And from VHQC today, everyone, the MVHIN Network, thank you and have a great day. Bye.
Thank you.